It's really a great pleasure to be here, and it is my first time to Wisconsin. It's too bad that I can't spend more time, but it's been lovely so far. And I want to tell you that I'm really just learning about your organization, and I'm very impressed with the work that Christine just detailed in terms of the scope of projects that your group is able to do, and the level of sophistication of the work that you're doing. I'm extremely impressed. So again, to applaud your group and Christine, I really, I'm overwhelmed really at the good work that you're doing. I do travel the country quite a bit. I meet lots of groups and organizations, primarily groups that are doing tobacco work of some sort or another in different populations. And I think one of the things that I often observe is that people do tobacco in a box. That one of the things I think our country is struggling with, and I promise I'll get on to my presentation. One of the things I think our country is struggling with in our inability to continue to make strides and more progress in reducing tobacco use is that we've got ourselves in a box. We figured out a couple of things that work, and we just keep doing them over and over again, and maybe the rules have changed over the years. And that's kind of related to the theme of what I'm going to talk about today, which is these women are complicated, and they probably have multiple problems, and just even thinking about them as pregnant smokers is probably too reductionist and isn't really getting at maybe what's going on. And I already get that sense that you guys get that you're already addressing numerous needs of the population. And so, again, I guess I'll be speaking to the choir. So I was asked today to kind of give this complex talk. I had to do a little homework to put this one together. This is a pretty innovative kind of, again, out-of-the-box talk to kind of bring together these ideas about gender issues, women, tobacco, mental health, and substance abuse. This isn't one I do all the time, so I'll do my best, because it really crosses a lot of interesting areas. So these will be the kinds of concepts I'll try to go over today. My background, as Christine mentioned, is that I'm an addiction psychiatrist. There are not many addiction psychiatrists interested in tobacco, which is ironic, of course, since it's the #1 cause of death, especially in people with mental illness. So I'm one of only a handful of psychiatrists that specialize in tobacco. I've been doing tobacco now for about 15 years. So I'm going to try and describe the prevalence and trends in mental health and substance use disorder in women, especially in the perinatal period. So kind of highlighting some of the issues in the populations that you treat, the impacts of these mental health conditions and substance use disorders on women, pregnant women and their families, the unique challenges and opportunities working with this population, and any strategies, promising practices or research that speaks to tailoring interventions. So I had my work cut out for me when I was sent the objectives. Okay, so we'll start with something simple, something that you know already. Rates of smoking in women, are equivalent to men. They're highest in women who live below the poverty level. And an important thing happened in 1990, which was that more women died of lung cancer than even of breast cancer. So even though there's more breast cancer in the United States in terms of total numbers of cancer, lung cancer is the #1 cause of cancer death in women. That's what we always teach the med students that they get wrong. And it's shocking, right? Because lung cancer was relatively rare in women before 1950 and completely parallels the rise of smoking in women in the U.S. And that trend continues today. Okay, and there's a little bit of variability state to state, but we have a lot of women smokers in this country. In fact, this is kind of an easy way to think about it, to kind of summarize the issue. There's about 17 million women of reproductive age smoking in the U.S. That's our target population. So it's a lot of lives. This is what we're up against. This is what we don't want. This is what we want to prevent. So what are the themes then? The themes are the people who continue to smoke during pregnancy. It's no accident. They're the women with the lowest socioeconomic status, and increasingly studies are showing that they're also women who have mental illness and substance use disorders. And that's very new research, like from the last 5 years. Nobody thought to ask those questions before. Quitting is more difficult for these groups. Behavioral counseling really is the first line treatment. We'll talk about meds. Nicotine replacement in particular can be offered if the smoker is unable to quit, but its efficacy at this point is uncertain. There's a lot of questions about that. The use of nicotine replacement, though, is always better than cigarette smoke. Always, always, always. So given that choice, and that is a tough choice, nicotine is better than Marlboro. Because the number one risk to the baby, of course, is the lack of oxygen that comes from cigarette smoke. So these are tough clinical choices we have to make. And the best scenario, of course, what we should really work on and strive for is that we should help these women quit before they get pregnant. That's really our best scenario. And there's not that many opportunities in our healthcare system to do that. And then the biggest difficulty in kind of putting together a talk like this and even reviewing the literature is there's so many gaps. There's so much we don't know. We have to guess, we have to piece things together, we have to make assumptions because we don't always have the data, and there's never enough studies of gender to really say things for sure. So this is kind of our best guess. And again, I know this is review for a lot of you, but there's so many consequences to mom and baby in the presence of tobacco. There's difficulty actually becoming pregnant and contributors to infertility. There's all kinds of pregnancy abnormalities, like that the pregnancy is outside of the uterus, what's called ectopic pregnancy. Abnormalities in the placenta, abnormal bleeding, miscarriage. If the baby makes it, low birth weight, preterm birth, stillbirth. Additional consequences to the baby: SIDS, sudden infant death syndrome, asthma, chance for cleft lip, cleft palate, ear infections, and the new one, attention deficit disorder. And increasingly we're going to find that moms who smoke have kids with neuropsychiatric conditions. Again, this is association data at this point. It's just saying that this is associated with this. We don't know that smoking causes attention deficit disorder. We just don't know at this point. We don't know if these moms carry a genetic risk for attention deficit disorder that they're passing on to these kids, or if they have attention deficit disorder themselves. We just know that there's association, that these conditions are highly linked. And as Christine mentioned as well, there is geographic variation in this. You know, Wisconsin unfortunately tends to come out as one of the states a little higher in smoking rates than some other states. It's a little higher as well in terms of smoking during pregnancy. Although there are some questions about some of this PRAMS data, because in the thousands of women that it samples, it's not as big a sample as some of the other national studies. So there's always questions about maybe it's not as accurate as it could be. But these are our best guesses for rates of smoking during pregnancy. And this is showing you the rates of smoking in the last 3 months of the pregnancy. So the people that persisted in their smoking. And important differences in racial and ethnic breakdown. So people who smoke during pregnancy tend to more likely be white and Native American. Those really are the two highest groups, although of course you'll see it in the other racial and ethnic minority groups as well. And we said how low socioeconomic status is an important factor. In Wisconsin, again, there is even a breakdown by county. Some counties are higher than others. I'm not from around here, so I look at a map like this and it doesn't make a lot of sense to me. I say, I don't get it. So, some of these counties are real dark. There's not an obvious pattern to me. Are these counties poor? Are there issues? I don't really know. I don't know your state that well. So just for fun, I said, I wonder what the distribution of Native American tribes is in Wisconsin. And it looked a lot like the highest smoking and pregnancy rates. And maybe Christine can tell me later about how, although your programs have been extremely successful, there's low utilization among the Native American groups. 4%, she said. So that would be an interesting question I'd like to hear from the group about what that's about. Probably politics. Somewhat. So isn't that interesting? I'm sure that's not the only explanation, but that was my first guess, and I thought it kind of mapped onto it a little bit. Okay. So when we think about smoking and pregnancy, again, there's kind of three main stories here. A lot of women will quit right before they get pregnant or right after, discovering that they could be pregnant, like around the time right before they're going for their first prenatal visit. These are the women who tend to have higher SES, a non-smoking partner, and lower levels of nicotine dependence. So the people who continue to smoke, again, who are about half of these young women, are the ones with the lower socioeconomic status, more mental illness, more other substance use, uninsured, and Medicaid populations. Again, you guys know that already because you're doing your targeted approaches in these Medicaid centers, in WIC. You understand that you need to kind of go where the smokers are to reach your target population, and I think that's a very effective strategy. You may not reach these people in primary care, and you kind of get that you need to go where they are. And I think that's a really important part of being effective with this population. So again, a lot of these smokers quit initially, but the bad news is that many of them relapse in the postpartum. As many as 2/3 of them will relapse after delivery, and these tend to be women who have a smoking partner, lower SES, again, higher levels of addiction to nicotine, those with mental illness, those with substance use disorder. So the same kind of factors you could see contribute to the poor outcome for all the different scenarios. So just to review that, this kind of says the same thing. So before pregnancy, rates of smoking in women kind of mirror the national average, 20-25%. During pregnancy, we get them down to about 13%. We wish they'd be lower than that, but a fair number of women do quit. But this is quite troubling. That almost immediately after delivery, rates go way up to almost 20% again. In fact, that's led to a lot of research now. It's very experimental and preliminary. We don't know for sure that this is important, but there is research that's happening now to look at hormonal changes. Because the biggest change that happens between here and here is that progesterone levels plummet. So progesterone is the pregnancy hormone. It's extremely high during pregnancy. People wonder if it's protective and it helps people to stop smoking. And as soon as your progesterone level goes down, is that why women are at such high risk for relapse in the postpartum? Nobody knows. It's really just a theory at this point. So people are trying to do research and understand that better. Is there something about those changing hormonal levels that are contributing to this very high relapse after delivery? But as of now, we just don't know. So these are the goals of Healthy People 2020 that our federal government has set up for us. We're not going to make it, right, because this is only 6 years away. So we failed to meet the goals of Healthy People 2010, and we're going to probably fail to meet the goals of Healthy People 2020. The goals were to reduce the prevalence of women smoking prior to pregnancy to 14%, so we're not there, right, because we're at 20 to 25% right now. To reduce the prevalence of cigarette smoking among pregnant women to 1%, we're not anywhere close to that, we're around 13. And to increase the percentage of pregnant smokers who stop smoking to 30%. So unfortunately, these are very good goals. There's nothing wrong with them. But we've been having these kinds of goals in our country now for decades, and the truth is that we're just not making a lot of progress. We've all been talking about pregnant smokers now, probably since the 70s. And the truth is that the field has not made that many advances. I think that's a fair thing to say. So along comes the psychiatrist to make some observations. Well, it turns out smoking rates are extremely high in people with mental illness. Maybe that's a part of the story. And this is some of the best national data that we have in terms of smoking rates in the U.S. in people who have mental illness or substance use disorder. So this data says if you don't have a mental illness and you live in the United States, your chances of being a smoker, your rate of smoking is about 21%. But if you have any type of mental health condition at all, even a mild one, your chances of smoking are going to be double that at 40%. And if you break it down by the kind of diagnosis that you have, if you have an anxiety disorder, again, your smoking rate will be about 40%. If you have depression, that's referred to as an affective disorder, your chance of smoking will be about 45%. And if you have a substance use disorder, you can see you have the highest rate of smoking, over 60%. So now we can say this group really has a rate of smoking 3 times higher than the general population. But that's not the end of the story, because these conditions are very likely in women. At least some of them. Depression, for example, is 70 times more likely to happen in women than men. If you look at cases of depression in a year, it affects 8 to 9% of women versus 4 to 5% of men. So it's a condition that is seen much more commonly in women. So if we're talking about smoking rates are high in depression, obviously, then that you can infer that that's impacting many, many women in our population. I've been doing this work in smoking and mental illness and substance use for almost 15 years. Is Dave McMaster here, Mac? Maybe he's coming later. But he's also a champion that's been doing this for a long time. Some of us have been doing this for a long time and kind of shouting that this is an important issue. And it's the country's finally catching up to us. So the government, just last year, the CDC finally recognized that this is an important national issue. They put out this document. You can find it free on the internet. It's called Vital Signs. And it's really the first public recognition by the CDC that smoking rates are higher in people with mental illness. That has that's actually extremely important, this kind of recognition, because in terms of disparity groups and priority funding, this group really has been the forgotten smokers, and they haven't been prioritized in any major funding or treatment initiatives, even though they probably now are a third of all the remaining smokers in the U.S. So this was quite historic and important that this document was released. It's also a very nice document. It's in color. It's about 4 pages long. It's a terrific tool in terms of psychoeducation. about the relationship of smoking and mental illness that you might even find useful in your work that you could download and use. New York is a state that has a very effective tobacco control program where they track tobacco, and they have a lot of money for tobacco programs. And you can see here, it's a little small, but over the decade from 2000 to 2009, New York has been able to chip away at their smoking rate. So smoking rate in New York has gone from 21% down to 16%. So now they're getting down to one of the lowest states in terms of smoking rate. Again, because they spend $40 to $80 million. They put a lot of resources into helping their population and a lot of free treatment resources. But in New York, over the same period of time, if you had poor mental health, your smoking rate didn't go down at all. So it was 33% in 2000, and 10 years later, it's 33%. So that also means that something about the way we've been approaching tobacco, even when we spend $40 to $80 million, isn't reaching some people. And that's important, because that's like what I'm saying about, we got to kind of think outside of the box. Instead of just doing the same things over and over and over again, maybe we need to consider a new approach. Okay, what do we know about people with mental illness? Well, we've known for a long time that if you had what we call serious mental illness, serious mental illness usually refers to disabling conditions like schizophrenia, bipolar disorder, the kinds of illnesses that people have for their whole lifetime. Their symptoms may never really go away. They require hospitalization, they may require lifetime medications. We've known for a long time that those people can quit smoking, but their chances of quitting smoking are less than the general population. I think we've known that for a long time. There's been debate, though, about conditions like depression and anxiety, kind of the milder mental illnesses. For a long time, people thought, oh, those people can quit smoking, just like any other smoker. And the new data is showing that's not true. They can quit smoking, but they also have a disadvantage. That if you look at them over their lifetime, they're fewer what we call former smokers, and they have a little bit more difficulty in quitting smoking too. So the truth is that if you have a mental illness or a substance use disorder, you're going to have more trouble quitting, and you're going to have less likelihood of quitting smoking in your lifetime. And then this is just more examples of that. So in big studies of depression, you look at all these people with depression in the US, different age groups, fewer of them become what's called a former smoker. So a former smoker is somebody who used to smoke who doesn't smoke today. But if you have depression, you're less likely to ever make it in that former smoker. You say, oh no, I'm still smoking today. So people with depression, less likely to quit smoking over their lifetime. This comes from the Wisconsin group. So you know this. They're doing all kinds of good things in Madison at the university. Megan Piper, I'm a big fan of hers, and other people at the university. And they've been a tobacco research center powerhouse for years. They're starting to do more studies now of smokers with mental illness. So this is an analysis that she published. Again, people with anxiety disorders, mild conditions. They had panic disorder, social anxiety disorder, and generalized anxiety. What we think of as milder conditions, right? These people go to work. These are our neighbors, our family. They're in this room. These people are among us. These are milder conditions. Well, if you have one of these conditions, you're going to be less likely to quit smoking, and you're going to have more withdrawal symptoms. So lots of implications then for quitting smoking treatment. It's very quiet in here. I don't know what that means. Let me just pause and say, does anybody want to make a comment or a question before I continue? That would be okay with me. If not, I'll just continue. Yes. Okay.
That's why there are rates increased.
So that's a great question. There's a lot of folklore that people with mental illness and substance abuse can't quit smoking. The number one thing is that it's going to make them relapse for their illness. It's going to derail them. It's going to make them use heroin again. The quick answer is none of that's true. But keep in mind, if we do things like this, and we learn that really they are going to also have more nicotine withdrawal symptoms, that helps us understand that if that's true, remember, they're going to interpret that as my illness is coming back. So we need to work with people. We need to make sure they are getting adequate treatment, including medication. But I think that there's a lot of hope for treatment, and most of the research studies show that people don't get worse in terms of their mental illness when they try to quit smoking. Okay, so let me say a couple points about treatment, and you may know this already, but when you want to understand how addicted people are to nicotine, this is the single best question that you can ask people. So hopefully you do this already. Hopefully you ask every tobacco user you meet the time to first cigarette, the TTFC. How many minutes in the morning until you smoke your first cigarette? It is the best. You can ask one question and be done, and get a lot of clinical information about people. Because if they tell you they smoke in the first 30 minutes of waking up in the morning, they're at least moderately nicotine dependent. And for most smokers, that's a good crude estimate that they might need medication. When you work in a mental health center like I do, almost everybody tells you they smoke in the first 5 minutes of waking up in the morning, or they even wake up in the middle of the night to smoke, which are indicators of more severe nicotine dependence. So that's a really good assessment question that gives you a lot of clinical information. So just to give you some information in terms of context about people with comorbidity, this is what happens when you ask people in addiction treatment how many minutes in the morning till they smoke their first cigarette. 50% almost say that they smoke in the first 5 minutes. So if you're going to bring your interventions into substance abuse treatment to try and work with women smokers or pregnant women smokers, they're going to be really addicted to nicotine. This also gets at your question. So people have done these kinds of studies to say what happens when we bring tobacco treatment to addiction treatment. So this was a big study done across the country where they said we'll go to regular addiction treatment, and some of them will get tobacco treatment added on, and some of them will not. They'll get treatment as usual. And the good news is that the people that got the tobacco treatment, in addition to their usual addiction treatment, they didn't drop out, right? That's the number one fear. So when you call the addiction treatment programs and you say, I want to work with you, I want to come to your place and help people quit smoking, and it won't even cost you anything. And they say, oh no, you can't come here. You'll send all of our patients away. They'll all run away from you, and then they won't come for addiction treatment. You can say, oh no, Dr. Williams, you showed them a slide. See, no, patients don't run out of addiction treatment when you offer them smoking treatment. Not true, that's a myth. There's been studies of that. Patients don't relapse back to alcohol and heroin when you give them smoking treatment. In fact, their abstinence from those other drugs is better. So again, those studies have all now been done. In fact, the craving for the other substance goes down too. So it enhances their outcome, and it doesn't worsen it when you give them tobacco treatment. Okay. Smokers with depression, remember that question that we said is a really good assessment tool. How many minutes in the morning till you smoke your first cigarette? What's called the TTFC. Smokers with depression are more likely to say that they smoke in the first 30 minutes of waking up in the morning than people who don't have depression. In fact, a lot of them say they smoke in the first 5 minutes of waking up in the morning. What does that mean? It means that smokers with depression are more biologically addicted to nicotine than smokers without depression. So if we're not using medication as part of the treatment, they're less likely to succeed. They're going to have a harder time. They're going to suffer withdrawal and probably drop out of treatment. In fact, women who have depression and quit smoking during pregnancy are the women who relapse back to smoking. So if you look at, this was a smallish study, but it was 65 women who quit smoking during pregnancy. Half of them went back to smoking postpartum. And the ones that did had depression and anxiety. They either had postpartum depression or anxiety symptoms. That was a factor. So they had symptoms in the postpartum that led them to be more likely to relapse, but that wasn't the only thing. Some of them just had it in their history. They weren't even depressed postpartum, but they had had depression before, and that even made them at more risk to relapse back to smoking. So it was both. They didn't even have to be depressed today. Even a history of depression made them more likely to go back to smoking. So this is saying, this is their depression score and their anxiety score. It's saying that the smokers, people who smoked, had more depression than people who didn't smoke after delivery. People who smoke had more anxiety symptoms than people who didn't smoke after delivery. So one of my first questions to you, and you don't have to answer this, but would be, in your toolkit, are you screening for anxiety and depression? Maybe you are. You know, screening for postpartum depression is really common now. But maybe you need to add an anxiety couple of questions too, if that's not in there. Seems to be important. This was even a little bit better study, looking at relapse postpartum. So who relapsed back to smoking after they delivered their baby? Well, the fewest women who relapsed had no depression or anxiety. Okay? The next highest group had depression, the next highest group had anxiety, and the ones that had the most relapse had depression and anxiety both. So the poor women that have both depression and anxiety, they seem doomed. They seem at the really high risk for relapse back to smoking, more than women that only have depression or anxiety alone. This is very powerful. But the other thing about this data that I want you to see is that it's very recent. So this one's 2009, this one's 2012. Like, nobody knew this 10 years ago. That's why it's not a part of current practice necessarily. This is really new. This one's my favorite. We've been treating pregnant smokers for decades and nobody ever thought to do a urine drug screen. In 2013, somebody said, maybe we ought to do a urine drug screen on these women. And guess what they found? A lot of drugs. In fact, I've been pregnant. I have 2 grown daughters. People did all kinds of tests to me. I don't remember them asking that much permission. Why didn't they do a drug screen on me? It doesn't seem unreasonable. Okay, but they didn't. I'm pretty sure they didn't. They find a lot of drug use. 35% of the urines come back dirty, right? 1 out of 3. That's a lot. They're almost all marijuana. Your pregnant smokers are smoking marijuana. P.S. That's why they're not stopping smoking. This is a huge finding for the field. This is huge. The biggest thing about this study, the thing that's even more shocking than what I just told you, is that they don't even stop. 25% of them are still using in the 3rd trimester. So those women using marijuana are really addicted to marijuana because 25% are still, 20% are still using it in the 3rd trimester. These are women that we are uncovering that are addicted to marijuana. And that's probably why they're not quitting smoking, that we have just been chipping at a much bigger problem. That's what I think as a psychiatrist, as a specialist in addiction. And you know what? This is partly because we're all siloed too. And I find this all the time in smoking and mental health. It's so hard to introduce tobacco into mental health because it's been siloed into primary care and public health, and I'm always trying to build those bridges, so I get it. Smoking and tobacco is pretty, and smoking and pregnancy is pretty good now, but you guys now were siloed from everything else. That's why nobody ever thought to drug screen. So I think siloing has been part of the problem.
Can you speak just a little bit more about addiction and marijuana? Because I think there's some confusion about, is it actually marijuana they're addicted to? Is it something that's in the marijuana? Is it the feeling, the high, or is it the actual substance? We don't know?
Well, I think these women are addicted to marijuana, and whatever that means. Addiction is a complicated human behavior. You know, is it biologic? Is it psychologic? They're dependent because they are pregnant. They are using despite consequences, and they are unable to stop. So in kind of the crude estimate of what dependence is, they have continuing use despite consequences, and probably an inability to control use. So even though we don't understand the intricacies just based on this slide, I would say that these women are addicted. In terms of what do you do for that, what's the treatment for marijuana, it's primarily a behavioral psychosocial approach. No one's probably even talking to them about marijuana. No one's even knowing that they're using marijuana. So they're not really getting the counseling that might even help address the problem. So maybe that's the picture we need from now on. Okay. And again, look at this paper, 2014. This one's hot off the presses. Because this is like the first time that some of this has been done. Now remember, since the 70s, you guys have been doing smoking in pregnancy. But there's been another whole field of healthcare professionals doing drug use in pregnancy. But they don't do smoking. Right? There are only substance abuse clinics where they give pregnant women methadone and other kinds of programs. But finally in 2014, somebody said, well, maybe we ought to ask our clients about smoking. Again, just imagine these silos. So if you go into the substance abuse programs where they have special tracks for pregnant women, somebody said, well, maybe we should ask them about smoking. 60%, like much higher than the general population. 2/3 smoke right before pregnancy. Some are able to quit. Again, high relapse rates postpartum. In this study, interestingly, the depression didn't seem to matter in terms of who relapsed and who didn't, but it's just one study, so it's hard to know. This is just groundbreaking because now a substance abuse program finally thought to look at smoking. That's a good thing. So again, you might reach out with all your knowledge and resource to these programs. You may be doing it already. Again, very interesting. So if you go to the substance abuse programs and you say, who are the women who smoke here, who are pregnant, it's the women with mental health disorders. You always get the same answer. It's always the same people. The women in substance abuse programs who have depression, anxiety, are the ones smoking. Right? Because they all have substance abuse disorders. But the ones with mental health conditions are more likely to be the pregnant smokers who have more trouble quitting. So it really, again, it's a very, very complicated clinical problem now. It's really saying you're not going to be effective in treating tobacco in pregnancy unless you have an integrated approach that can simultaneously deal with the other drug use, probably marijuana, and the depression and anxiety. I mean, that's a very complicated clinical situation. That's probably what's going on with these women, in addition to poverty and chaos in their lives and the other things, because they're low SES. It's really a challenge. Okay, if you go into the methadone program and you study the ones who are pregnant, 80% of them smoke. So again, extremely high tobacco use rates. They tend to be the youngest women, the unmarried women, the ones with low SES, and the ones with mood disorders and anxiety disorders. You just hear the same, no matter where you look, you find the same story. So the ones that didn't smoke, who were pregnant methadone users, again, less likely to have the mental health conditions. It's pretty overwhelming. So for any smoker, we already know it's pretty hard to quit without treatment. We say many people want to quit, as many as 70% of tobacco users say they want to quit. Few quit without treatment. Treatment works. We say cold turkey bad, only gives you a 5% success rate. With treatment, your success rate is going to be somewhere between 25 and 50%. So really the message is you got to quit with treatment. It'll greatly increase your chances of being successful. What's treatment? I'll talk a little bit now about medication, very briefly. But really, ideally, for every tobacco user, the best treatment plan is counseling plus medication. That gives every tobacco user the greatest chance of success. I'll make a few comments briefly about the use of nicotine replacement, bupropion, and varenicline. In terms of using these medications in people who have mental illness or substance use disorder, there really is no reason not to use them. We should use them in those patient groups. It's a first-line treatment. It's recommended that we use medication in all smokers. So we should use them in people who have mental illness and substance use disorder. Remember, those smokers are very addicted. They're going to have a lot of withdrawal. So they don't have any chance of making it without the meds. They probably have a greater need for the medication in being successful quitting. The meds are safe and well tolerated. And there's studies that now show, patients leave hospitals AMA when they don't get the meds. So people are experiencing nicotine withdrawal in a hospital setting. That's very uncomfortable to them when they can't smoke. We should give patients safe and comfortable detox when they're in the hospital. They shouldn't have to suffer with withdrawal. And we should really be using these medicines much more aggressively in any type of mental health or substance use program. Just a reminder to the audience, these are very safe medications. Nicotine is not what causes cancer in cigarette smoke. Right? It's only one of 7,000 chemicals. It's really the 6,999 other things that are not nicotine, that cause cancer, that cause heart disease, that cause lung disease. We joke nicotine is really one of the safer things in the cigarette, even though it's the one that causes addiction. So for most people, the pregnant woman is the one exclusion, but for most people who use tobacco, they would be much better off using nicotine medicine than continuing to use tobacco, which is so toxic to our bodies. These are kind of the rules when you give someone nicotine medicine. Remember that we tend to underuse it, and that's what makes it less effective. In order for nicotine medicine to be effective, you have to tell people, use a lot of it. Use it all day long. Use it aggressively. Because the story is that it's hard to give people enough nicotine medicine. They're used to getting very high levels in their body from smoking. And it's really a challenge to give someone enough nicotine medicine that they're going to be comfortable. So one of the reasons why it seems that nicotine medicine fails is because we may not give enough. Nowadays we do a lot more combinations, giving people patch plus lozenge together. And that seems to be more effective than giving people one nicotine medicine alone. So nicotine is very safe. We also have, there's been studies looking at nicotine medicine in patients with depression, and it clearly works. It also has been studied in patients with alcohol and other substance use disorders, and it clearly works in those populations as well. Okay, so this is the wild card. What about pregnancy? Well, the message has changed, even in my own career. I feel like what I'm going to say to you today is even more conservative than what I would have said to you 5 years ago. So the pendulum kind of swings back and forth on this a little bit. We used to say, you know what, the number one risk to the baby is the lack of oxygen that comes from cigarette smoke. That the toxins in smoke are clearly the most risky thing to the baby. And if a woman is unable to quit with counseling alone, in a period of 2 weeks, the next step really should be to add medication. And the medication that we would typically add in that algorithm. So 2 weeks counseling, if she fails, we would say add NRT. You would go with a nicotine approach. And I probably would still do that clinically. What's making it difficult is that the clinical guidelines are a little bit waffling on this. A couple of studies have come out recently where they actually did trials of pregnant women giving them nicotine medicine, and it didn't show that it worked. It didn't show that it was unsafe, it just didn't show that it worked. So now people are more confused. Remember, the risk of the nicotine is not to the mom. There's really no risk to her. And the risk to the baby is quite small from, say, nicotine medicine. And it's mostly a theoretical risk. But the idea is that if a woman uses nicotine medicine, the nicotine from that medicine could affect the developing brain of the baby. That's the potential risk that people worry about. And people are afraid of that, frankly. Now, the truth is that is a risk like this compared to the risk of tobacco. Right? Because you're not going to even have a baby if you use tobacco. So the idea that the small amounts of intermittent nicotine, not in a huge dose, the minimal effective dose, that's what we would say, we would think some women really need that to be able to stop smoking. But the literature right now is much more mixed about that. There's not a clear recommendation to use nicotine replacement, and the reason was because recent studies didn't show that it increased that woman's chances of stopping smoking. So I have to tell you the truth. So at this point, the recommendations say we don't know. It says this nicotine has not been sufficiently evaluated for safety and efficacy. There's conflicting evidence whether or not it helps women in pregnancy stop smoking. Again, I think if it were my patient and a woman couldn't stop with counseling alone, and I talked to her and she understood the risks, and she said to me, "Doc, I know I can't do it without this. I think we could talk about it and we could choose to use it, but it has to be kind of case by case." And I'm a physician, so I'm okay with that, and so obviously the physician has to be okay with that. You tend to use the minimal effective dose. You tend to not use patches, because again, you want to give a break. You don't want to just give nicotine round the clock. Better to just give it as needed, and you would use it with supervision. So a little bit more conservative than what I might have even said a few years ago with regard to nicotine in pregnancy. Now, I want you to understand that the reason that those studies showed that nicotine didn't work during pregnancy could be because during pregnancy, your enzymes get jacked up, and you might actually need more nicotine during pregnancy. So this is the problem too. In pregnancy, your nicotine metabolism is on overdrive. It's super fast because you're pregnant. So in order for nicotine to actually be effective during pregnancy, you need a high dose. So nicotine may actually be effective during pregnancy, and it could be that we haven't done the studies right. Do you understand? So it is really kind of a complicated story. Does that make sense? Bupropion. Bupropion is an antidepressant that helps people to stop smoking. When we use it to help people to stop smoking, we use it in the same dose as it's used as an antidepressant. We usually use it 2 weeks before the person has their quit date. It can cause headache and insomnia, but is otherwise pretty well tolerated. You never give it to somebody who has a history of seizure or eating disorder because it has a risk of seizure. It works in smokers with depression, but it works in smokers who even have no history of depression. It works in smokers with schizophrenia. It's been studied in smokers with alcohol dependence. So it works in a range of smokers. I would not use it in pregnancy. I think most people would not be wanting to use it. It's actually felt to be fairly safe in pregnancy. It's not known to cause any fetal abnormalities or adverse pregnancy effects. But because it carries the risk of seizure, I think most people are not comfortable using it. Women can get preeclampsia, a condition of high blood pressure that's associated with seizure during pregnancy. So I wouldn't go near this one because I would feel like I might be going to court. This feels like it could be dangerous to me. So I wouldn't choose this one as a pharmacology, even though I guess it does have the potential to be safe. It is also transmitted to breast milk. Varenicline is Chantix. Chantix works in a different way than the other medications. It's what's called a nicotinic partial agonist. That means that it stimulates the nicotine receptor in the brain, but it doesn't stimulate it fully. It stimulates it partially. If it were to stimulate the nicotine receptor fully, it would be addicting, like nicotine. The chemical components that allow it to stimulate it partially give it an advantage. It means that it could stimulate that system of the brain, and instead of causing high or addiction, maybe it causes well-being. By stimulating that system of the brain, it also helps the person so they don't have nicotine withdrawal symptoms. And then the last thing it does is, if you imagine this is your nicotine receptor, and you're taking Chantix, or varenicline, and varenicline binds to your nicotine receptor, and then you smoke a cigarette, what would you imagine happens to the nicotine in that cigarette? Somebody has to give me an answer.
To block it?
Right, the nicotine has no place to go. So if the receptor is already attached to the Chantix, because the Chantix attaches to the same nicotine receptor, and a person has a relapse and they smoke a cigarette, the nicotine kind of has no place to go. Now, nicotine doesn't stimulate the system. That means that the person doesn't get a hit from smoking their cigarette. Their nicotine didn't give them pleasure like it did for the prior 43 years. And that's a good thing. So Chantix has these couple of ways it works together in combination to help people to stop smoking. And studies have shown that Chantix, when given alone as monotherapy, seems to be the most effective treatment. Now, you can't talk about Chantix without talking about the 6 o'clock news. So we've all seen the reports. It has a black box warning that although, I want to say this clearly, although it never has shown up in research studies, case reports, which means individual people, have said that they took Chantix and it caused them to have depression, suicidal thoughts, agitation. I think that's the only one. So the FDA's job is to log those reports when they get called in and to report them to the public and to say, we don't know if Chantix causes these problems, but our job is just to keep a record of them and to warn the public that it's been reported. So that's exactly what the warnings about Chantix are. Individual people calling the hotline saying, it happened to me. I want you to know that research studies of probably more than 9,000 patients now have never shown that. And I'll show you some of that data. So for example, after those warnings came out, this study was published looking at 80,000 people who were treated in the UK for stop smoking treatment. You know, the UK has that really bad socialized medicine that people don't like. And with that really bad socialized medicine, anybody there can get full free access to stop smoking treatment completely for free. So they can look at what happened to all of these people who had full access to treatment. 80,000 people through their primary care network. 63,000 got nicotine replacement, 11,000 got Chantix, and 6,000 got bupropion. And they said, what happened to these people? Did the Chantix people have really bad side effects and bad outcomes? And the answer is, they did not. There were some bad things that would happen in this study, as you would imagine would happen when you have a sample of 80,000 people. There are people who get depressed. But the rate of depression and having suicidal thoughts and reporting that you were agitated was exactly the same if you got nicotine or if you got Chantix or if you got bupropion. So there's no evidence that Chantix itself carries more risk of that. But I'll show you more. This is another study that's come out, newer data, putting together 17 studies that Pfizer has published, more than 8,000 people who have been in different Chantix studies over 15 years all over the planet, included more than 1,000 people who had psychiatric illnesses. But people say, but that's not good enough. They're a pharmaceutical company. We still don't believe it. It could somehow be biased if it's only Pfizer. Even if an independent person looks at it, it's still Pfizer data. We still don't believe it. So in this paper, they said that's fine. So what we'll do is we'll also look at 35,000 people in the U.S. who were treated through the Department of Defense. Regular U.S. citizens who got treatment to stop smoking through the Department of Defense. They either got Chantix or they got nicotine medicine. And they wanted to see if Chantix was associated with more depression, more aggression, more suicidal thoughts. And it was not. It was not associated with more suicide. It was not associated with more depression. It was not associated with more agitation. There's like 10 of these studies. But I can tell you, I always visit psychiatric facilities, and as I go in the door, the first thing they say to me is, Dr. Williams, we just want you to know, our docs have a no Chantix policy. I say, really? You know, they say black box warning, black box warning, black box warning. I say, that seems strange. It really is a potentially life-saving treatment. Seems odd that you would single one out like that. Oh, I don't have the slide here. Especially because everything psychiatrists use has a black box warning. Including bupropion has a black box warning. So I just don't think it's fair to single out one medicine. True, all medicines carry risk. But at this point, it is not clear that varenicline is more risky than really any other medicine that we use.
Does the agitation include the wild dreams that a lot of people stop at?
So one side effect of Chantix can include what's called vivid dream, but that's also a nicotine side effect. That's a possibility with the patch. Again, for most people, if they have that side effect, you can tell them to discontinue it, and it goes away in a day. So it's usually not very troubling to people, although it is a possible side effect. Just to show you again another study, this was looking at Chantix in patients who had major depression, and these were people who had some degree of illness. They were on antidepressants, they had symptoms, so they were not symptom-free. Chantix worked. It was more effective than placebo, so when they took Chantix, more of them were able to quit smoking. So again, proof Chantix can help people with depression to stop smoking. That's good news, and the safety data was very good. There was no evidence that Chantix worsened depression, even in people with depression. So the safety data looks good. There was no difference in this sample. Even the depressed patients did not have more abnormal dreams, anxiety, agitation, restlessness, or suicidal ideation compared to the patients that got a placebo. Okay, Chantix is not recommended in pregnancy. That's pretty clear. There's no information about the safety to the unborn fetus, and it is transmitted to breast milk. Okay, what about counseling? Counseling, we want to typically give patients counseling with medication. We typically time counseling around the quit date. Different things work, but there's a dose response, so the more minutes we give people, the more effective our counseling will be. It doesn't matter, luckily, what kind of discipline you are, lots of things work. When I go to train a mental health audience and they've never done tobacco treatment, one day in their career, I say to them, raise your hand if you do skills training, relapse prevention, problem solving, coping skills, stress management, cognitive behavioral therapy, and they all raise their hand. And I say, oh, good news, you know how to do stop smoking treatment. Those are all the evidence-based approaches for treating tobacco, and to a behavioral health audience, these are the things they already know how to do. So that's the good news about tobacco counseling, is these are very, if you're any kind of counselor, you often know how to do these strategies. These are common modalities. They're used in a variety of different healthcare settings. They're not unique to tobacco. You don't need to go to Tobacco Counseling Institute. These are the same kind of counseling approaches that work for lots of different chronic disease models. Relapse prevention is relapse prevention.